We're back in the Dermcast studio, Rob Casquejo in Miami, Florida, and I have a very familiar face today in the studio. It's Dr. Matt Zirwas. Welcome, Dr. Zirwas.
Rob, thrilled to be here. Thanks for having me.
And I've seen you lecture, I don't even know how many times in my 20-year career, but I've never had a chance to sit and talk with you, so this is going to be cool for me. We're going to focus on atopic dermatitis because this is, I mean, you're one of the heavy hitters in AD. So give us your background real quick. A lot of people know you, but let's put it out there for the viewers.
So practiced in Columbus, Ohio, got interested in dermatitis as a resident, and at the time was interested in what I would have called non-atopic dermatitis. So the kind of patient that I really liked and still do were the 45-year-old who's had scattered eczematous dermatitis on the trunk and extremities for 2 or 3 years, no personal history of atopy, no history of childhood rashes. So somebody who was this contact dermatitis, is this, why do they have dermatitis? And really got interested in trying to figure that out and spent 15 years trying to find, are there unique therapeutic approaches? So rather than the normal, here's topical steroids, here's some Kenalog or prednisone taper, methotrexate, immunosuppressives. Are there things we can address that will get to the underlying cause of the dermatitis? And what I learned over those 15 years is generally there was not. And I no longer refer to that patient as non-atopic dermatitis. Now I really believe that they all truly are atopic dermatitis, and they meet the criteria, right? The FDA has really imposed on us that we should be using the AAD criteria or the Hannafin and Reka criteria, and those criteria really say that those patients, the scattered dermatitis, just a couple of years, no childhood history, no atopic history, that they really do have atopic dermatitis.
Okay, so this is probably where most of us find difficulty in treating, let's say, new onset or recent history atopic dermatitis, because it doesn't match up with the history you read in a textbook. So talk to us about evaluation of that patient. You've got that history. Where does your evaluation go for that kind of patient?
Yeah, and that's such a good, because what I find is people often get kind of stuck in the, why do you have this? What is this? And my evaluation of those patients is actually really quick. So it used to be these were 30-minute visits for me. Now they're some of the easiest 5-10-minute visits because, number one, I'm going to make sure that they're not using any obviously problematic products, right? They're not using Bath and Body Works, lavender, cinnamon, peppermint, it might as well be called contact dermatitis body wash, right? I'm going to make sure they're using, Dove Bar, CeraVe, Cetaphil, Aveeno, something like that.
By the way, I am a huge fan of Plumeria. I mean, that takes me back to my college days, man. The girls all. Anyway.
So I'm going to make sure that there's no obvious source of contact dermatitis. But again, the scattered dermatitis, it is just so rare that it's really contact dermatitis. We're not talking hand dermatitis in a healthcare worker, new onset eyelid dermatitis, and just scattered generalized dermatitis. So it's really, making sure that I don't think they have scabies, making sure that there's no obvious source of contact dermatitis. But first visit, I am very comfortable telling that patient, yes, you have eczema, and specifically, you have a type of eczema called atopic dermatitis. And I'll often use the analogy for them that saying you have eczema is like saying you have a headache. The real question isn't do you have it, it's why do you have it and what treatment is going to work. And saying you have atopic dermatitis is like saying you have a migraine headache. Well, now there are specific treatments that we know will work for you that would not work if you had eczema or dermatitis that was being caused by something else.
Okay, and so before we go into therapeutics, let me just rewind here. The bullet I picked up really, is it fair to say that one of your first evaluations is going to be around the physical sources of an eczema? Is that sort of what I heard? Okay.
Yes, looking for, and I really use the term an obvious external trigger. I sort of sometimes forget to really talk about that because generally by the time a patient gets to me, they've seen some other good providers. Any obvious physical external triggers have been addressed already. but that is absolutely, I really use the term obvious because I don't spend a lot of time anymore really going into a lot of depth on, okay, make sure you're using Dove Bar. These are the 3 moisturizers. Use one of these 3 times of moisturizers, or 4, and making sure that there's nothing obvious. But I go very quickly. We should now be, when we walk into a room and somebody has clinically spongiatic dermatitis, and I don't think you really need a biopsy for it. If there's something atypical, you can biopsy it. But when you walk in the room and you're looking at somebody and you think they have spongiatic dermatitis, your assumption should be this is atopic dermatitis until proven otherwise.
Okay, that's good, and that's not necessarily. I don't think necessarily that's what folks do. Okay, so
no, and it's not what I did, right? Until 5 years ago, absolutely not what I did. Atopic dermatitis was a very specific diagnosis that I used to think you had to have childhood onset. You had to have
hyperlinearity,
atopic, right? Flexure rib,
right.
No, if it's sponge derm, it is atopic dermatitis unless proven otherwise.
Okay, so this is good for me because this is the way I think, and sometimes I think I'm missing something by thinking that. So I feel good because you just validated, the way I was trained in the way I think clinically. So that's cool. So we identify it. Like, all right, we've ruled out these other things. We've got AD here. It's what we think it is, and it's this sort of variation where you don't have the typical history. Now you've got it. So there's a lot going on in therapeutics now for this. We've got these mechanisms that are both given to us topically and systemically. So give us some primer on the new stuff that that we have access to these days.
Where I want to first start, because it is really important to me that the patient and I are kind of aligned. And patients come in thinking that the way that you treat their dermatitis, they think there's some external trigger and we've got to, we'll figure that out and then I'll be cured. And if they're not going to buy into me treating them with a drug until they buy into, I can't get this better just by changing something in my life. And so my 30-second, probably 1 minute spiel that I've been developing for years goes like this. So if it was you. So you've got atopic dermatitis, and here's what that means. Your skin is supposed to look like this, and anything that gets on your skin is just supposed to sit on the surface. Your skin looks like this, and so it has these gaps in it, and anything that gets on the surface of your skin gets through those gaps, then your immune system overreacts to it, and that leads to this itchy rash. Now, I know what you're thinking is, well, let's figure out what's getting through, and I'll get away from that stuff, and then I'll get better. That would be great, but these things are your own sweat, air pollution, pollen in the air, right? And so we might be able to get you temporarily a little bit better by changing your lifestyle, but really it's going to be about treating you to help close these gaps and keep your skin from overreacting. And fortunately for you, we have amazing medications now that are totally different from any of the stuff that you've used before. They're not steroids. They don't have all of these terrible side effects that we used to worry about, thinning your skin and all of those kinds of things. So we really have good options for you. So at that point, and really I'm assuming we're talking about moderate to severe atopic dermatitis, so meaning relatively widespread, something that I can't easily treat topically. I'm going to assume that we're talking about moderate to severe atopic dermatitis, so not things that I can easily treat topically. But before I go into that, I am just going to say we have nearly miraculous topical therapies now for atopic dermatitis. Historically, we're used to the idea that topicals are slow, not very well tolerated, so burn, sting, things like that, or they're steroids, right? So we have steroids that work fast and are well tolerated, but people don't want to use them and they're not good for long-term use, or we had non-steroidals that weren't that great. We have an unbelievably effective topical non-steroid now in topical ruxolitinib or Opzelura. We're going to have 2 more phenomenal drugs in the next year or 2, so Vtama and Zoriv, that are both already approved for psoriasis or finishing up their atopic dermatitis trials. Those are phenomenal drugs as well. It really is to the point now, if it wasn't for cost and insurance restrictions, there's almost no reason to ever prescribe a topical steroid.
Okay, so I'm glad you said this. So, because what I want you to do is frame in terms of practical clinical knowledge, that where are you placing these products now? So your paradigm of treatment, we've identified we want to treat. You've mentioned the products, and for sake of, you're going to lecture on these things, JAK inhibition, et cetera. So where are you? Are you starting people out of the gates on these non-steroidals in lieu of a steroid, or are you pulsing? You're starting with a steroid and then you're going following it. What's your clinical bias for this? Is there something on paper that supports it, or
So I would say that my first line is always prescribing a topical steroid and probably a TCI, but that's largely because there's no chance I'm going to get insurance coverage for any of these non-steroidal topicals until I've done those two things. And if it happens to be really easy and their atopic dermatitis responds quickly and immediately to the steroid and a TCI, great. I don't need to go any further. But I'm prescribing those. I'm generally telling the patient, hey, we got to try these first. I don't think they're going to be the long-term answer, but your insurance won't let me do anything else until we try this. And then it really, at this point, Opzelura is the only real option that we have because the others aren't approved for atopic dermatitis yet. But those three non-steroidals, I think what we're going to end up finding, Opzelura is going to be the fastest. I think that Vtama its shtick is going to be that it gives the real potential for a durable, we clear your atopic dermatitis up, and then you may not need to put cream on for 4 months or 6 months. And then the Zoriv is going to, I think, sort of be in the middle. So I think it's going to be very fast, very well tolerated. It's probably going to be the one that is what I might describe as easiest to use, because we're not going to have to talk about folliculitis or contact dermatitis like we have to talk about as potential side effects with Vtama. We're not going to have to talk about the black box warning like we have to talk about with Opzelura. So I think Zoriv will probably be the easiest to use. So there are going to be three very distinct topicals, and it'll vary from patient to patient in terms of which one I use as my first line.
Okay, great. So, and you said it this way, but let's say that the availability is not a barrier. Would you go so far as to say that these are potentially first-line products?
Yes.
Okay.
So they are as effective, so in my opinion, as effective or more effective than topical steroids, and safer.
Right. Without the baggage.
Without the baggage.
Right.
And so, right, from a medical perspective, we've got drugs that are as good or better in terms of efficacy and better in terms of safety, better accepted by patients, right? We know 70% of patients have steroid phobia. From a medical perspective, taking cost, insurance, everything else out of it, these should obviously be first-line treatment. Okay. Just no question about it.
Great. So let's close on this subject that you've treated and now you're having problems.
Yep.
Okay, it's just not getting better, and then these questions arise now. What am I doing? So obvious things, biopsy this. Let's make sure we know what we're doing. Maybe it's already been done. What are your go-to things in those scenarios?
So I have a really low threshold for going to systemic therapy in these patients now. And again, having honed this discussion over years with hundreds of patients, it actually is a really interesting thing. People ask me, well, what drug do you pick mostly? Like, what's your first line go-to? And I tell you, I have the patient pick. So I'm never selecting, here's the drug you should be on. And so here's my spiel. So I'm a huge believer in shared decision making, and in a very specific way. I always try to give patient one option, so A versus B, and I try to give 3 bullet points for A and 3 bullet points for B. Then once they make kind of that initial decision, I might do a second decision after that, but I'm not going to give them 5 options. Say which one sounds best to you. That just doesn't work. So it's always 2 options. So here's my spiel. All right. So we're finished. I've talked to this and that, and we got great new medications. So I'm going to give you 2 options. First, and then you're going to tell me which of those 2 sounds better, and then we'll go from there. So option number 1, we could treat you with a pill. Works really fast. You're not going to have to give yourself any shots, but it does slightly weaken your immune system. Option number 2, put you on a shot. You're going to have to give yourself a shot, a tiny little shot at home once every 2 weeks. It's going to work a little bit slower, but start working within the first week or 2. Pill starts working in the first day or 2. Shot starts working in the first week or 2, but it doesn't weaken your immune system at all. So again, pill, really fast, slightly weakens your immune system. Shot, fast, not as fast, doesn't weaken your immune system. What do you think? And the patient then will almost always have a pretty strong either couldn't imagine giving myself a shot, or I wouldn't want to take anything that might affect my immune system. And those are really the two things. And so then if they say, really don't want to give myself a shot, then we're going to talk more about the oral, so a JAK inhibitor. And whenever I talk to them about a JAK inhibitor, so they say the pill, okay, great. So first thing to warn you about, so it does slightly weaken your immune system. That's going to put you at a little bit increased risk for shingles or for getting a cold sore that could actually go bad and spread all over your whole body. But we can address that really easily. I'm going to put you on a medication called valacyclovir. It's like a vitamin that prevents shingles and cold sores. Really inexpensive, been around forever, totally safe. That's been the only problem shown with the slight weakening of your immune system. But then the medication's going to come with some warnings from the pharmacy that are going to sound really scary. First thing to tell you, I don't think that these warnings are anything that you need to be concerned about, but they're going to sound really scary. So things like heart attacks, strokes, death, blood clots, cancer. And the FDA wants you to know, the reason you're getting those, the FDA wants you to know that a different medication that's fairly distantly related does increase the risk of those things in people who have other problems. But the medications that we're talking about, we have tons of information about them, tons of data over years and years. None of those things have shown any increased risk for people on the pill that we're talking about with you.
And so this is the complexity of this, because there's that black box warning. It has to be addressed and it has to be explained, and it becomes like a long explanation.
Yes, that was probably a 1-minute discussion about it. And notice what I did not say. I did not say it does not have those risks, because to be able to say it's been proven that it doesn't have those risks, there would need to be a 5-year, 5,000 patient, controlled study. But what I said is all of the information, all of the data we have, none of it has shown any risk of those things with this medication used for treating atopic dermatitis. I do still get some patients who, whenever they hear, oh my God, if those things are even remotely a possibility that it might increase the risk of those things, forget it, I wouldn't want to be on it. Okay, fine, then we're going to go back to the shots. And I often get asked, between Rinvoq and Sabinco, what's the difference? Which one? We don't have any comparative data, and having used tons of both, I think they are incredibly similar drugs. It really comes down to access for me, which one is going to be easier to get a patient on. Then we've got the two biologics. So let's say I wouldn't want anything that's going to weaken my immune system. Okay, then we're going to talk about the biologics. So we've got 2 different shots for you. One of those has been around a little longer, works a little bit faster. You're going to give yourself a shot every 2 weeks, and indefinitely, as long as you're on it, it's always going to be a shot every 2 weeks. The other one is extremely similar, hasn't been around quite as long. I think it works a little bit slower, but if it gets you better, and there's about a 7 out of 10 chance that it's going to work great and get you better, we can probably switch your injections from every 2 weeks to every 4 weeks. So again, one's a little faster, it's been around longer, so we're more certain about how well it works, but you're going to have to do shots every 2 weeks indefinitely. Newer one, not been around quite as long, may take a little bit longer to really get better, but once you get better, we could probably switch it from every 2 weeks to every 4 weeks. Which one sounds better to you?
Right.
And then again, I'm letting the patient decide, is it more the speed of working and we have more data because it's been around longer? Is that more important to them? Or is the possibility of being able to go to every 4 weeks instead of every 2 weeks, is that more important to them? So again, I'm letting them make the decision.
Okay.
And again, most patients, when I'm presented with that choice, have a pretty clear option. And it's there isn't like one. It's not like everybody goes on this one or everybody goes on that one. It's really up to the patient, and it really depends on the patient which one they pick.
Okay, so all of this is great information, and there's so much detail to this because we've got new therapies. We're getting used to them. There's the labels we have to deal with, the educational part, but they all work pretty good. So you ready? You want to end on some rapid fire?
You got it.
Just kind of shoot at you.
You got
and
it.
kind
Let's
of fire
go.
back. Okay. So leave somebody on a non-steroidal topical therapy indefinitely. Yes or no?
Yes.
Okay. So switch from a medication of similar mechanism, so let's say a JAK inhibitor not working, switch to another JAK inhibitor, yes or no?
Yes.
Okay, so expound on that just a little bit.
So there is a what I consider a meaningful difference in JAK selectivity between the two JAK inhibitors. So Cibinqo is actually a little more JAK1 selective than Rinvoq, and we don't know enough yet about the pathways. In a given individual, it may be that having a more specific JAK1 inhibition might work better or worse than having a less specific JAK1 inhibition. So although they're very similar drugs, I'm not convinced that they're so similar that failure on one predicts that the other one's not going to work. Just don't know yet.
Perfect. Okay, so let's flip it. IL-13. Go from one to the other?
Yes.
Yes.
And it's always fascinating to me the idea of why is it possible, what are the reasons why the IL-13 or IL-4/13 inhibition may not work? It may be that that's not the right pathway for that patient, and in that case, switching drugs wouldn't make any sense. It also may be something specific to the drug. So it could be they metabolize one of them differently than the other. They have a neutralizing antibody for one of them. They have a slight mutation on the receptor or their IL-13 that changes the binding affinity. So if it's any of those things, then switching from one to the other could make a big difference. I'll say that in general, I'm more likely to, if the biologic didn't work, I'm more likely to go to a JAK rather than switch biologics, but I have done, let's switch biologics.
Okay.
So I do switch within class, but I'm more likely to switch classes because that makes more sense.
Right.
But it does also make sense to switch within class.
Okay, great. So I think that's very useful because people struggle with that. Okay, history of malignancy, JAK inhibitor or IL-13?
IL-13.
Okay. History of infectious disease like, let's say, valley fever, tuberculosis, either or neither?
IL-13. So
okay.
there is literally no question you could ask me other than allergic reaction to IL-13 inhibitor that I would say that would prevent me from using it.
Okay, great. Tachyphylaxis with systemic medication, real or not real?
Real, but extremely uncommon.
Okay. Allergies to systemic medication in this realm, so JAK or IL-13, real or not real?
IL-13, real, but extremely uncommon. JAK inhibitors have not seen it at all.
Got it. Topical steroid allergies, real or not real?
Definitely real, less predictable than we thought. So anytime I have a topical steroid allergy, I generally go to desoxymetasone as my topical or tacrolimus ointment. Both of those have very clean vehicles, and allergy to them to the active is extremely unlikely.
Got it. Okay. Allergenicity to purified lanolin, possible, not possible?
Possible, but very uncommon.
Great. Okay. Favorite band? Let me reframe it. You're on a desert island. You can have one artist, limitless songs from that artist. Who is it?
Taylor Swift.
T-Swizzle?
I got 2 teenage daughters. I'm slowly becoming a teenage girl.
All right. You know how much those tickets cost, don't you?
Oh, just bought them this week?
Okay, well, there it is.
Yeah. Yeah, got terrible seats.
I thought I had you figured out, but I was not expecting Taylor Swift. Like that's.
I'm turning into a teenage girl.
Oh my gosh, I love it. All right, amen. You know what? I admit, you know, I dig it. I think she's a talented girl. You know,
she is.
She's a little angry at men in general, but hey, man,
hey,
you know,
I can understand that.
Yeah,
I can understand that.
I dig it, man.
Yeah.
Hey, this was so cool for me. I'm so glad, you know, that we had a chance to catch up. So let's make a point to do it outside of the studio, man. I'd love to sit and chat with you a little bit.
You got it.
Okay, man. Thanks again to our special guest, Dr. Zirwas, who's been an avid supporter of the SDPA for so many years. And it's a pleasure to have him here in Dermcast Studio. Thanks for watching, and watch out for his lectures on the podcast. Rob Casquejo for the SDPA in Miami, Florida.